أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear students, I am Professor Dirrhoea. First of all, the slide which is in front of you is thanks for the good listening. You are all good listeners, I hope. So this is the slide which is seen. You have seen this on the first occasion. Now we will start the discussion on a very, very common problem, and that is the diarrhea. Before this subject, the acute diarrhea has been explained by my colleagues. So it's very difficult to define the diarrhea because the different physicians, they have got a lot of discrepancies among the definition of this condition. Diarrhea is a big subject, especially specifically speaking about the loose motion or a diarrhea of a long duration. So I have actually decided to discuss in two parts. Part 1 will be discussed today, that is on this date, that is on the 26th, and on 27th you will find the part 2. So it will be divided into two, but it is a long discussion. A scenario is described first of all, so you can understand what is the importance of this diarrhea. A 24-year-old student presented in the medical OPD for the intermittent loose motions associated with a vague abdominal pain for the last 3 months. He noticed fresh blood 3 to 4 per day in his stools, accompanied with the painful defecation. Recently, he admitted significant loss of weight. His paternal uncle died of the carcinoma of the colon 3 years back, probably with the same complaints. On an examination, the temperature was 99 degrees Fahrenheit, pulse 121 per minute is a high volume, BP is 114/76, anemia is positive, and tenderness noticed at the left iliac fossa. The left iliac fossa was tender during my examination, and the pulse is high volume because of the anemia, because of the temperature, which is low grade fever, you can say. So every point is important in the history. If you take the history properly, you can find the differential diagnosis, you can make the differential diagnosis. Investigations were done and the blood CBC with hemoglobin was 8.9 gram. The mean corpuscular volume is 7. ESR was 88 millimeter per first hour. It's a higher ESR. And the random blood sugar is 79 milligram, which is a normal one, although it is slightly lower in the age group. And the urine DR is normal. Ultrasound whole abdomen was unremarkable because nothing is reported in the ultrasound abdomen. You know, the abdomen viscera, they are not very exposed to the ultrasound waves. They cannot describe properly the lesion. The question is, what may be the differential diagnosis and what other investigation might be helpful? What is the likely diagnosis? How will you manage this case? Differential diagnosis is a manifold because this is a diarrhea of chronic duration. It may be turned out to be anything. It may be a chronic amoebiasis. It may be giardiasis. They are common things. They are common problems in Pakistan. Maybe patient is suffering from the irritable bowel syndrome because the patient is young. Maybe he is suffering from the inflammatory bowel disease. Maybe he may be suffering from the tuberculosis of the intestine or abdominal tuberculosis. Maybe suffering from the lymphomas and carcinoma of the colon may be possible. Whipple's disease is a rare disease, although it occurs in 1 in 30,000 to 40,000 people in the world. It is a very rare disease. The other investigation might be helpful is the direct evidence, and you do the lower GI endoscopy and see what is the position of the colon and take the biopsy and do the biopsy. You do the stool examination in detail. Detailed examination is required. And the most likely diagnosis in this case, to me, it seems to be the inflammatory bowel disease rather than the other diseases which I have just told you. To me, I'm not sure about it, but in the end, when I will complete my lecture of part 1 and part 2, you will see that I was justified my diagnosis or not. Management is according to the diagnosis. You will manage the case according to the specific diagnosis. The discussion is with the chronic diarrhea is the definition. It is a controversial matter. According to the WHO and according to the American College of Gastroenterology, they define diarrhea by weight. In the urban population, if it is more than 200 gram to 250 gram per day, it is for more than 3 months, it is a chronic diarrhea. The another definition may be volume. How much volume is there? Diarrhea can be defined by the volume. But thirdly, the frequency. Diarrhea may be defined by frequency. Increase in stool frequency. 3 or more stools. Previously it was 1, now it is 3, 4. Diarrhea may be described by the formation and by the morphological appearance of the stools. So there are many definitions of the diarrhea. So the diarrhea is the condition in which there is more frequency of the stool formation or defecation, which can lead to the systemic disturbance. This is the correct conception of the chronic diarrhea. And it is a progressive in nature. It will lead the problems in the future. It means the causes are manifold. Chronic fatty diarrhea, malabsorption syndromes, which I have described previously. The chronic inflammatory diarrheas, like irritable bowel syndrome, for example, and इसके अलावा gastroenteritis or enteritis. The chronic watery diarrhea, secretory diarrhea, or osmotic diarrhea, or drug-induced diarrheas. They are all written in the books. Watery nature of the diarrhea. Absolutely water. There is no defecation matter in there. Maybe secretion occurs because the osmosis occurs. There are a lot of causes of secreted diarrhea, osmotic diarrhea, or drug-induced diarrhea. Because you are in third year, I don't want to confuse this matter. We will discuss, inshallah, in the final year. Infectious diarrhea is the commonest cause of the diarrhea in this country. Another diarrhea is related with endocrine disturbances. For example, in cases of the hypothyroidism, or for example, high serotonin levels can cause the diarrhea. The functional diarrhea is the diarrhea of exclusion, that is the irritable bowel syndrome. This is the last to diagnose is the IBS, remember. Last to diagnose always. History should be taken properly. Young patients think about IBS, of course, tuberculosis, functional bowel disorder, irritable bowel syndrome in young patients. In older patients, the colonic cancers and diverticulitis are the commonest causes. More than 70 years of age, if these type of symptoms occur, look and exclude the colonic cancer and diverticulitis. The pattern of diarrhea alternates with the constipation seen in colonic cancer, laxative abuse, in diverticulitis, in functional bowel disorders, that is irritable bowel syndrome. Intermittent diarrhea, we are seen in diverticulitis, in irritable bowel syndrome, and in malabsorption syndrome, depending if some part is absorbed and some part is not absorbed. For example, in gluten enteropathy, for example, the patient has taken no wheat in 2 days. The patient is asymptomatic then. On the third day, he had taken the bread, and there is gluten, because he was suffering from the gluten enteropathy, there was a diarrhea. Persistent diarrhea occurs in inflammatory bowel disease. It is persistent. And in laxative abuse, the patient who are taking continuously the lactulose or the other loxobron or other purgatives, Biscodil, etc., this will cause the persistent diarrhea. Always remember in your history taking and decide that the patient is suffering from small bowel diarrhea or the large bowel diarrhea. I have said in my previous lecture in cases of the celiac disease that you have to decide that the small intestine is involved or with proximal colon, or distal colon is involved, or the middle colon is involved. A small intestine with proximal colon, there are large stool diarrhea, always very offensive stools. And the frequency in this case is very, very high, 7, 8, 9, 10 per day. And abdominal cramping persists after defecation. Distal colon involved, small stool diarrhea. It is, frequency is not much. Frequency in this case is after 4 hourly, 6 hourly, you have got the stool formation. Because the colon is irritated, you have to go to after every 2 hourly or 3 hourly. Abdominal cramping relieved by defecation. This is called tenesmus. Tenesmus is the condition associated with the colitis. And colitis occurs in cases of the irritable bowel syndrome or in diverticulitis. It may be seen in some cases of the IBS also. The comparison between small and the large bowel involvement, I have already mentioned out in my previous lecture that in small bowel diarrhea, the large stool volume, in large bowel diarrhea, there is small amount of volume, stool. Increased frequency with a large volume stool, frequency in small bowel diarrhea is very high. Here the frequency is 2 hourly, 3 hourly, half hourly in large bowel diarrhea, because if there is irritation in the colon, the sphincters at the rectum and the anal canal will open and the stool will come out. even involuntary defecation occurs. Here, small bowel diarrhea, no urgency, you can hold. But in large bowel diarrhea, there is urgency because the sphincter, they will relax and the stool will come out automatically. No tenesmus. Tenesmus is present in the large bowel diarrhea, not with the small bowel. Mucus is usually not seen in the small bowel diarrhea. Mucus may be present in the stool in the large bowel diarrhea. Blood is rarely seen in small bowel diarrhea. It is usually mostly seen in the large bowel diarrhea. Central abdominal pain may be present with the small bowel diarrhea. Pain in the left iliac fossa or right iliac fossa, relieved by their defecation, is the characteristic feature of the large bowel diarrhea. Diurnal variation, another important point. You ask the patient if there is diurnal variation. No relationship to the time of the day, infectious diarrhea. Morning diarrhea and after meals because of the increased gastrocolic reflex. Gastric cause may be possible. Or functional bowel disorders, it is the commonest cause. In most of the young people, irritable bowel syndrome. Because of the increased gastrocolic reflex, inflammatory bowel disease may be exaggerated in morning. Nocturnal diarrhea, always organic, remember, in your life. Only in the night, there is a diarrhea. In the day, there is no diarrhea. Diabetic neuropathy and diabetic gastropathy will cause this condition. Another condition which can cause the nocturnal diarrhea is inflammatory bowel disease. Weight loss, despite normal good appetite, hyperthyroidism, malabsorption, and the irritable bowel syndrome can cause. Associated with fever with inflammatory bowel disease, weight loss prior to the diarrhea onset. Diarrhea was not seen, but weight loss was prior. Like tuberculosis, pancreatic cancer, diabetes mellitus, hyperthyroidism, in malabsorption condition like gluten enteropathy, for example. So weight loss is already there previously. Now stool characteristics, watery stool are seen in chronic watery diarrhea. Water content is more. For example, in cases of the cholera, it is purely watery diarrhea. In viral diarrhea, again, it is purely watery diarrhea. Blood, mucus or blood plus mucus, chronic inflammatory diarrhea. Foul, bulky, greasy stools, chronic fatty diarrhea, malabsorption syndrome, greasy stools, bulky stools. Past medical history is important. Now, childhood diarrhea resolves and then re-emergence in the adulthood. It is characteristically seen in gluten enteropathy, which I have already discussed previously. In uncontrolled diabetes, again, because diabetes is controlled at one time and another time it is not controlled, it causes the autonomic neuropathy. So, in cases of the uncontrolled diabetes, diabetic diarrhea is the separate subject. Do not take it lightly. And in cases of the pelvic radiotherapy, again there is history. It will cause the inflammation to the colon, the pelvic radiotherapy, it will cause the large bowel diarrhea. Past surgical history of jejunal bypass or gastrectomy with vagotomy or bowel resection or cholecystectomy, it is called the post-cholecystectomy syndrome. Because nowadays the laparoscopic cholecystectomy has been practiced very, very, very large scale. Every day in our hospital where I am practicing privately, there are 3 or 4 cholecystectomy has been done by laparoscope. After 2 months, 3 months, the patient comes to me with the diarrhea. The post-cholecystectomy syndrome is associated. It is a condition in which there is a, pain in the abdomen, tenesmus is there, the gastric distension is there, and there is a diarrhea of small bowel diarrhea. So these patients are caused because bile is necessary. Remember, the cholecystokinin. Now there is no cholecystic. There is no gallbladder, so there is no effect of the cholecystokinin now. So lipids are not absorbed in these conditions properly, and the diarrhea occurs as small bowel diarrhea. Red flag sign, remember, always suggestive of organic causes. Painless diarrhea, recent onset in older patients is very important. Nocturnal diarrhea, especially if wakes the patient, if there is associated weight loss, if the patient is blood in the stool is there, if there is fever, if there is a large stool volume, more than 400 grams, 500 grams, anemia, hypoalbuminemia is associated, and increased ESR or CRP or other acute phase reactant is higher with the diarrhea. It suggests there is something going wrong in this patient. They are called red flag signs. The physical examination should be done properly. Inspection, palpation, percussion, auscultation. General appearance and the mental status, vital signs, body weight, orthostasis, volume depletion, autonomic dysfunction will cause the drop of the systolic blood pressure of more than 20 millimeter. Patient even collapse in this condition. Exophthalmos represent the hyperthyroidism. Abscess is seen in the inflammatory bowel disease and celiac disease. Lymphadenopathy is seen in malignancy, in infection, and Whipple's disease. Enlarged of the tender thyroid, thyroiditis, medullary carcinoma of the thyroid, clubbing of the fingers in liver disease, inflammatory bowel disease, laxative abuse, very prolonged use, and in malignancy. General physical examination and mental status. I say these are very important things which I have written. Now, skin lesions are also described with the examination. A dermatitis herpetiformis, the specific condition which is seen in celiac disease, associated condition. Erythema nodosum and pyoderma gangrenosum. They are again the very specific skin lesions seen in the inflammatory bowel disease. Hyperpigmentation is seen in Addison disease, with abdominal pain, Addison disease with hyponatremia, with Addison disease. Flushing is seen in carcinoid syndrome. This is argentefinoma, actually. Argentefinoma cells, they are activated, they are present in small intestine, and it causes the carcinoid syndrome. Migrating necrotizing erythema. This is a specific skin lesion which is seen in the glucogonoma. This is a tumor of the pancreas. Abdominal examination should be done to see the surgical scars, abdominal tenderness, masses, hepatosplenomegaly, borbogamous on auscultation. If they are, you can hear without stethoscope, even indicative of malabsorption or bacterial overgrowth or obstruction or the rapid intestinal transit can cause. Remember, the per-abdominal examination never completed before you will do the perineal examination and the rectal examination. Do not forget it. If there are signs of incontinence, skin changes from the chronic irritation, gapping anus, weak sphincter tone, these are the markers of the inflammatory bowel disease. In Crohn's disease, specifically perianal skin tags, ulcers, fissures, abscesses, fistulas, stenosis are clearly visible. You are ashamed in front of the patient, okay, please, I want to check your perineum and the perianal area. I want to do the perirectal examination. Please do it. Please take the consent of the patient, do it. If the patient consented, because you have to reach the diagnosis. Fecal infection or masses might be noted, especially specifically speaking, in old ages. It is known as retention diarrhea, fecal infection. If you do the rectal examination, if you put the one finger inside and disinfect the fecal matter, all the above is cleared, and there is a lot of fecal matter comes out as in a diarrheal fashion. Systemic examination, wheezing and right-sided murmurs are seen in carcinoid syndrome, which I will discuss in the final year. Arthritis, inflammatory bowel disease, and Whipple disease, which I will be discussing in final year. Investigation will be done: CBC, TSH, serum electrolyte, serum albumin, stool evaluation, stool pH. If less than 6, if it is acidic, it means carbohydrate malabsorption occurs, because it will form the lactic acid, which reduces the pH of the stool. If leukocytes are there, fecal leukocytes, electrolytes are written wrong. Well, fecal leukocytes should be discussed. If they are 4 to 5 per HPF, is more than that, it means that the fecal leukocytes is indicative of the inflammatory bowel disease. Fecal occult blood test is very important. It indicates that the lesion is upper GI tract involved. Electrolytes is very difficult in Pakistan. Fecal sodium, how much is there? Osmolar gap in stool. Differentiate the chronic body diarrhea category, but it is very difficult examination for the lab is concerned. So it is usually not done. Fecal fat, if it is more than 14 grams in 24 hours, it indicates the small intestine is involved, stool ova and parasites with 2 to 3 samples, Giardia lamblia antigen indicated for the diarrhea, 7 days to 10 and more than 10 stool per day. Clostridium difficile toxin. Now, Clostridium difficile diarrheas are the post-antibiotic diarrhea. If you give the antibiotics and diarrhea occurs, it is more chances that the Clostridium difficile cause this diarrhea. This is called the Clostridium difficile associated diarrhea. Considering testing stool for the laxative use. Now, stool are tested for the laxative because this is watery diarrhea, electrolytes are lost, sodium is lost, the potassium is lost, the chloride is lost. But this is a very difficult examination. I already said lab examination, it is not an easy examination. Endoscopy is the main examination, optosigmoidoscopy. Take the sample from this and do the histopathology and make your diagnosis. If you are awaited for the diagnosis, the treatment is non-specific. Dietary modification, small, more frequent meals, decrease carbohydrates in diet, decrease fat intake, avoidance of the milk because the lactose intolerance can cause diarrhea. Avoid sorbitol and mannitol. No good evidence to support use of bulking agents. ये कहते हैं ना बोगोल ले ले आप तो आपका डायरिया कंट्रोल हो जाता है, तो इसकी साइंटिफिकली जो है ना एविडेंस नहीं है. Bismuth substance said yes, Pepto-Bismol can be used for a smaller period of time. Opiates and opioid agonists like loperamide, like diphenhydroxylate, codeine and other narcotics can be used for a shorter period of time unless the diagnosis is confirmed. Specific therapies can be given accordingly when the diagnosis is made. If the diabetic diarrhea or moderate and severe diarrhea predominant the irritable bowel syndrome, or in cases of the predominant IBS, diarrhea type of predominant IBS. Now clonidine, if it is the anticholinergic effect, it is used in this condition. Otherwise, the somatostatin can be used by certain physicians in refractory diarrhea, in AIDS, with specific diarrhea like post-chemotherapy and graft versus host disease, and in hormone-secreting tumors. The somatostatins like octreotide is beneficial. Bile acid binders like cholestyramines in small bowel diarrhea is effective. Pancreatic enzyme supplementation in chronic pancreatitis, it is effective. So this is the end of the part 1. I hope that what I have said, you have understood that, and wait for the part 2 coming on the next day, because the lecture is a very big one lecture. I have divided it into 2. This is the first part I am concluding now, with the hope that you have listened this lecture very carefully, and inshallah ta'ala tomorrow I will continue with it. Assalamu alaikum wa rahmatullahi wa barakatuh. Again, thanks for the good listening in the end. I'm very, very thankful to you.